Good morning, everyone, and welcome to Science 10. I would like to talk about the surgical aspects of high-grade gliomas. The surgery for high-grade gliomas has experienced a shift in paradigm of how we conceive if we want to resect these tumors. In fact, back in the 1920s and 30s, Walter Dandy used to do a complete hemispherectomy whenever they encountered these type of tumors. And then that paradigm has shifted, where they found that there was no real benefit in resecting such tumors. But then again, in the 1990s, we find a reshift in the paradigm where there are more studies supporting greater extent of resection rather than just supportive, rather than not supporting the extent of these resections. And why is that? Well, many factors come into play. The modern guidelines now say that primary surgical resection for all types of tumor, high-grade gliomas included, should be provided with a neurological function is preserved. Also, the studies that have shown a greater resection to prove that there is a progression of free survival were debated, but the adequate assessment of these studies was into question because they didn't take into account the volumetric analysis of such surgeries. And this has brought back the question when we started to do more volumetric analysis to find that a greater amount of resection has actually benefited it. And this was illustrated in the paper by Senai and Berger in 2011. Another factor that takes into play that we don't have the luxury, as other oncology surgeons do when they operate at other parts of the body, we don't have the luxury of achieving negative margin. So we always have to leave a part behind to preserve the function. And the location of these functions can vary from one patient to another. So the basic concept in glioma surgery, and high-grade gliomas included, is maximum resection versus, on the other hand, the functional preservation. And I will go through a few slides that will illustrate how we can achieve and balance these two. So how can we improve the extensive resection? First, with the availability of the neuronavigation, this has helped us have better and more precise location for the tumor, which has helped us in minimizing our craniotomies and has helped us as well in achieving extensive resection. The downside of the neuronavigation, however, if it's used on its own, is that it's not real time. As time goes by in your resection, the accuracy of the neuronavigation is lost because of the shift, the brain shift. And this was proven, with different literature, that neuronavigation standing alone is not enough to achieve that. Another way of improving the extent of resection is the intraoperative MRI. And this has gained popularity, especially here in Saudi Arabia. We already have 2 centers in Riyadh that are using the intraoperative MRI. A third one has been already installed and is beginning to be operational. And the intraoperative MRI has helped us resect the tumor and update our neuronavigation once we resect it to mask the error that has happened from the neuronavigation because of the shift. The 5-ALA, which has been introduced since the last decades, has also came into play to help us with localizing high-grade gliomas, as it uses the fluorescence where it lights up the high-grade tumors and it shows them in the area where we need to resect it, and it will help us to resect more and more with the use of the 5-ALA. We have had experience with the 5-ALA in KFMC. That was 2 years ago, but for logistic reasons, we're still trying to have it available all the time. This is another, actually a quite new technology that is brought by NICO, and it has been available in the market since 2012. And what it does is that it is mainly concerned for deep-seated lesions with the high-grade gliomas included, where they go through the sulci with a tube that is also neuronavigation assisted, so you can reach the deep tumors and resect them with minimum disturbance to the function. Now, moving on to the functional side, how to localize the functional tissue pre-op, we have a few modalities, one of which is functional MRI, and you can do it for the motor and the speech, and this is available in almost all the big centers. And this has helped us as neurosurgeons to allocate that functional area and stay away from it, which can be integrated into the navigation system as well. The diffuse tensor imaging has looked at the white fibers and their proximity to the tumor. So it's not just the cortex or the functional area, but rather also the white fibers and how they are shifted as we resect the tumor. Navigated TMS, or transcranial magnetic stimulator, is another modality that has been also used here in KFMC, Saudi Arabia, since 2013. We have done about 37 cases. The technology lies in stimulating the cranium while we check the EMG for the location of the hand area or the foot area or even the speech area with the help of our speech pathologists. Then we take that information and we plot it on to the MRI, which we transfer it to the neuronavigation, and it will help us locate the functional area. And then we can compare it with the direct current stimulator intraoperatively. The beauty about navigated TMS is that well tolerated by the patients, and it has shown it to be very accurate when compared to the DCS. And I'm proud to say that we already now have it at KFMC, and come April it will be available to all patients in Riyadh, where we can have a temporary file made for patients coming from other centers. So we can, my colleagues in other centers, they can send me the patient with the Bravo MRI. We will do the TMS, plot the functional area, and send back the patient to you. So that will be a very good utilization. Now, how to preserve function of the tissue intraoperatively, like we discussed with the TMS, the DCS is the standard of care, and it's also used for the subcortical function preservation and identification. So as you can see in the illustrations I just put up, where we can resect the tumor up until we reach the corticospinal tract, and we can also do direct cortical stimulation to identify the Broca's area. And then last but not least is we can always do an awake craniotomies to help us identify and preserve the function as we resect the tumor. And this is mainly done where the tumor is close to the eloquent area like the speech or the motor. And we are hitting about 50 cases of awake intraoperatively at KFMC at this time. Now, another thing about high-grade gliomas is there any role for recurrent surgery? And unfortunately, this is the only study that looked at the benefit of resurgery. And in that study, they mentioned at the end that even though that we have found clinical significance of reoperation once, twice, or even 3 times, but this has been shaded and biased by the selection bias, because when we look at the patients who have GBM, it's a very devastating disease, a very deteriorating disease. And those who manage to have a first resection, then go through the radiation and chemotherapy, and then come back with a recurrence, we have to take into account their Karnofsky score, their clinical status, and whether or not they will tolerate a second surgery or not. Those that did tolerate these second and third surgeries were fit to begin with. So the question lies in what is their genetics, not rather than the disease is going to come back, but how is it that they can tolerate? So we always have to take it with a grain of salt that if we are to do a second or third surgery, we have to look at it from the big picture rather than just, if we are to do a randomized controlled trial and operate on everybody, we will be faced with patients who cannot tolerate these surgeries. So therefore, it will be very difficult to justify that. So it always goes back to common sense rather than anything else. So in the end, I would like to put the whole picture into perspective of calling it information-guided surgery for glioma, where we have to have the functional information, the form information, the histological, and it would be nice if we would have histology available intraoperatively as we resect. That being said, it will be better for low grades rather than high grades, because high grades will be identifiable from the beginning. All this information has to go into the fact that it will help us to make decisions intraoperatively and to achieve the balance between high resection rate and low complication rate. Thank you very much.